I think I'll invite Dr. Manish Bansal, who is also going to present a case to shed some, give in short your view about the presentation just now. And Dr. Gaur Chaudhary, if he's here, of course, from him also, I would want to understand just a sum of what we saw just now. Yeah, Dr. Gaur.
I think, please.
You go ahead. Manish, please, you first.
Yeah. So both the patients basically communicated the same thing, same expectation from the doctor, that the doctor should be caring, should be willing to understand their problem, should empathize with them, should try to solve their problem. And this behavior and this care and concerning attitude towards the patient is what matters to them more than the actual treatment that we provide to them. And actually, most of the patients, they form their opinion about the doctor within first few minutes of entering the doctor's room, how he starts his interaction, and whether the doctor is intimidating, whether the doctor appears to be helpful. So all those things matter a lot, which tend to get ignored quite often in the busy practice, where we often are very blunt with the diagnosis and with the treatment recommendations, and there's shortage of time, not giving enough time. All those cause tremendous damage to that interaction that should happen. But that's what is happening.
Yeah, Dr. Gaur, your opinion.
I agree with all the observations. Bharti, I must compliment you. I hope you're there, Bharti Iyer. She was very, very to the point, and she made those points very relevant. I just have a question for Bharti, in fact.
Okay. So this was a recorded thing. I will just check.
So the question that I would have for either Bharti or the patients or for the doctor colleagues, including Beena and Manish and all, how do you balance time management? Because you see, the question is, I'll share with you a small story. I don't remember, Beena, when you joined SGPGI, but when I joined, that was 87. And in the year 87, I had a lot of time, Dr. Nayak and I. So we had a patient, and those days the rich people would send only their servants as a testing ground, how these doctors are, because we had just landed in Lucknow from outside. So we would spend almost 2 hours finding out about everything. And we asked a lot of questions. And at the end of it, one chap who had come, he said, I think I'll go back. I'm not interested in you people. So we said, why? So he says that, when I go to good doctors, I find that they are so crowded, their OPDs, and they are so busy. And here you don't seem to have any patients, and you are spending 2 hours on me. Now, it so happened that 2 years later, he brought his son with suspected lymphoma because he had lymph nodes. And he stood in the OPD. By that time, the OPD had become very crowded. And he was waving to me, and I told him, come in a line. So he waited for 2 hours, and then he came in. And he said, बहुत बदलाव आ गया. I said, क्या? He said, उस टाइम तो आप मुझे बुला के 2 घंटा बात करते थे, चाय पिलाते थे, अब आप इतने बिजी हो गए. तो I said, अब ये बताओ कि अब जब हमारे सामने लाइन लगने लगी दरवाजे के सामने, अब मेरी इज्जत भी बढ़ गई तुम्हारे आंखों के सामने. अब you tell me, what should I do? So good doctors in a way become the victim of their own success. And I really don't know what is the ideal solution. I mean, I just thought Bharti might be able to tell us.
I agree. Actually, it would be too simplistic to say that the solutions are easy. That's why we are going to discuss some ways out. Maybe it's not just the time, but how we connect, because with our whole presence, whatever time we have, how do we utilize that when we are in the clinic? So moving on with you, Dr. Manish, you had an interesting case, and we have really experienced people who can help us answer that. So I would invite you. Can we have his intro slide, please? Acha. So we'll go ahead with Dr. Manish. Will you introduce yourself first?
Okay, I will. I'm Dr. Manish Bansal. I am Director in Clinical and Preventive Cardiology at Medanta, the Medicity, Gurgaon. So actually, I recently came across this patient around 15 days back, and this was a very complex case, and it had resulted in a very complex interaction between him and me and the subsequent events. And I thought it would be better to discuss this here in this forum. This actually covers many of the topics that are going to be covered in the next 2 days. And I'm sure the points that I discuss will be answered or will be discussed subsequently in the subsequent lectures. So this was a 39 years old gentleman. He one day he developed chest pain, for which he went to a prominent Gurgaon hospital in the emergency room. There they diagnosed him to have suffered a minor heart attack. So angiography was done, which was normal, and he underwent some other evaluation also and was finally discharged on medications. So far it was everything fine, but the problem was that this patient, this person, was also a known case of hypertrophic cardiomyopathy for last 10 years. Now, to briefly, in simple terms, to explain this disease, hypertrophic cardiomyopathy is the most common inherited cardiac disease. Now, in this disease, heart muscle becomes abnormal, it becomes thick, and the architecture also becomes abnormal, because of which it can manifest in a variety of manners. It can cause breathing difficulty, it can cause chest pain, it can cause obstruction to blood flows. But the most dreaded complication of hypertrophic cardiomyopathy is the risk of sudden cardiac death. Because in these patients, heart muscle is abnormal in architecture. So there are abnormal currents that keep happening, which can result in ventricular tachycardia or very fast heart rate. And if that occurs, it will prove fatal within 2 to 3 minutes. So sudden cardiac death is the most dreadful complication of this disease, and hypertrophic cardiomyopathy is one of the very common causes of sudden cardiac death. So in every patient with hypertrophic cardiomyopathy, whenever we see any such patient, we have to assess the risk for sudden cardiac death, because this is a manifestation. We cannot wait for it to occur. We have to be proactive. We have to prevent it, because if the patient develops ventricular tachycardia, we won't get another chance to correct it, and therefore we have to find out who are the patients who are at risk for developing sudden ventricular tachycardia and having sudden cardiac death. So for this, we look at patient symptoms, whether the patient has had dizziness or fainting episodes, whether there is any history of sudden death in family, because it is a genetic disease. And then there are some features that we detect on imaging, which can tell us that this patient is at high risk of ventricular tachycardia. And if the risk is high, then we have to put in a device called ICD. That is a pacemaker type device. It is put under the clavicle bone, under the skin. This device, what it does is, whenever it detects that rhythm, it delivers an electric shock internally, which terminates that rhythm and saves life. That's the only life-saving treatment for ventricular tachycardia if occurs. So this patient was a known case of hypertrophic cardiomyopathy. He had not had any symptoms related to that, so he was being managed conservatively. This latest presentation was for chest pain, for which angiography was done. So when he was discharged from that hospital, his aunt, who is at a senior position at our hospital, she brought him to me for a second opinion. So when he came to me, I said that I wanted to do his echo again, because echo is the main modality for treating this condition. Echo gives us all the required information. So when I did echo, I found something which was very alarming. It indicated a high possibility of ventricular tachycardia and sudden cardiac death in him. But as I told you, he had had no symptoms related to that, no fainting episodes, no family history of sudden death. So this, and his recent Holter test, which is 24-hour ECG, that was also normal. So other features were indicating that the risk was low, but this echo finding was very alarming. So I asked him to get a cardiac MRI done, because that would be sort of confirmatory in this situation. So he got cardiac MRI done, and cardiac MRI was absolutely dreadful. I have never seen a more frightening MRI image than what I saw in his case. Half of his LV muscle had already been replaced with fibrous tissue. So it was a very, very frightening situation. Naturally, I recommended him an AICD. Now, AICD, as I mentioned, is a device which is put under the clavicle bone. It is an invasive procedure. It costs around 6 to 7 lakh rupees, and it requires replacement of its battery every 7 to 8 years. So it has a lot of implications associated with it. So now, when all this happened, this presented several issues before me. First was that I knew that this patient was a ticking time bomb. He was at very high risk of sudden cardiac death. Luckily, he had not had any alarming events so far, but it could happen anytime. And also, as I told you, his heart muscle had become grossly abnormal. He was at very high risk of developing heart failure also in future, needing heart transplantation. So I was in a dilemma. I had to convey this news to him. I had to explain all these risks to him, knowing that he was totally unaware of this. He had been seeing doctors for last 10 years, and he was absolutely oblivious of all these things. And I was going to be the first person to break this news to him. Now, in such situations, what we often tend to do is we try to present good things, optimistic part also, and then we gently tell the tough part also. But in his scenario, because of the sudden cardiac death risk, I did not have the luxury of that also, because I needed to convey to him that he needed an ICD immediately. He asked me whether he could wait. I was not in a position to say that he could not wait. So I had to very, very tactfully explain this to him. I explained to him the nature of his disease, why it happens, how it happens, and what we were going to do. I explained to him that it was only for prevention, it was not for treating, so there was no reason to get worried about it. But in spite of all this explaining, he did not believe me. The first reason why he did not believe me was that he was in absolute denial. Because accepting all that I was telling him would have meant a lot of implications for him, financial, psychological, physical, and so on. So he was not ready to accept that what I was telling him was correct. And also because he had been seeing various doctors for last 10 years. Nobody had told him any such thing. So his next question was, were they all wrong? Especially the latest echo. He said that my echo was done 3 days back. They said everything is fine. Now today you are saying that echo is not normal. I knew that the person who had done his echo, the last echo, had missed the finding, which had resulted me in getting MRI done, and MRI showed the abnormality. So it was actually missed, but obviously I could not tell this to him. I had to tell him that, you see, this is a very subtle finding. It may not be picked easily. So on one hand, I had to defend the previous practitioner. On the other hand, I was also feeling bad that, you see, I diagnosed a condition which could have proved fatal for him. Yet I have to be on the defensive side. I have to underplay this finding and explain this to him that, okay, maybe it was a subtle finding because of which it was not picked earlier. But the worst part was that he wanted further opinion because he was still not ready to believe me. I told him that you can go and consult 10 people. In fact, I said, you consult 10 people first and then come back, because I knew that with the findings that we had, there would not be any difference of opinion anywhere. in many other conditions, actually, that is not the scenario where there could be differences of opinion, and then that also affects how uh, we doctors are perceived by the patients. If the same patient goes to someone else and he gives him some other opinion, then it could be detrimental to my reputation or my credibility. In this case, although that was not that big a problem for me, but that is another issue that we have to face very often. But then later, after a few days, his aunt who had brought him to me told me that he was actually saying, and he was getting upset with her, that why she did not take him to a more senior cardiologist and why she brought him to me. Actually, this felt me, this made me feel extremely bad. It's not that we are not used to a second opinion requests. We know that most of the patients, whenever they are advised any major procedure, they seek second opinion. But here I was thinking that, look, you've been seeing doctors for last 10 years. You had this disease. Nobody picked this. I diagnosed this, which was confirmed on MRI later. Still, you are doubting me and want to go to a more senior cardiologist. So I think that was actually quite disappointing and demotivating for me. And then the another problem was that in his case, the whole issue does not end with him. It is a genetic disease. It gets transmitted to next generation. So I had to explain to him that he needed to get his children screened, which is very, very important. He has two children, 12 years and 13 years. So his wife was there. She almost had tears in her eyes. But this is again something which cannot be avoided. I needed to explain that to him. So over the next few days, he got his MRI reviewed at least 3 other major centers in Delhi who had the same opinion, and he consulted at least 3 other senior cardiologists who also had the same opinion that he needed ICD immediately. Although he's not yet undergone any further treatment and he is still in a dilemma. So this is all I experienced. Different scenarios, winning patients' confidence or trust, breaking terrible news to the patient, and also the issues of findings missed on earlier examination, senior cardiologist versus junior cardiologist, and likewise. So I would like to seek the comments of the other panelists on this case.
Thank you, Dr. Manish, for presenting so honestly. And I think this is something which many of us experience. And I think we learn over a period of time that we sometimes care for the patients, and that itself may mean that that doesn't mean that we always need to be nice to them. We have to actually truthful, and that may go the other way around.
Yes.
So that's true. And I think there is something called culture of safety. And if we follow that, and if we follow our own conscience, that should be the only guiding thing. But we have many more interesting panelists now. Dr. Gaur, if he's there, Dr. Tejal after that. The next panelist, Dr. Tejal, Dr. Chitra, Dr. Manas are also here. If they can just put in their comments also. Dr. Gaur, what would you say?
Let somebody else talk, otherwise I'll do all the talking.
Yes,
so,
yes.
But quickly I'll tell
Chitra,
Manish, suppose I were to play the devil's advocate, and I were to say that, look, you are a young fellow, and you made a startling discovery, and it pricked your ego that the fellow didn't want to follow you. The reference or allusion to senior versus junior hurt your ego. And
I'll put it differently.
I'll be a devil's advocate, and let's call a spade a spade. And one of the things that we all do, and even I did when I was young, is derived immense pleasure and satisfaction in proving my previous people wrong. I'm the latest kid on the block, and I have come out here with something that others missed. Do you think that's a disease that runs with many young doctors and we aren't able to really get over it? Sometimes we may be right, but what about the humility factor as individuals? So I think, we have to first look at ourselves also. Number two, if suppose, let's be sensitive to other doctors. If suppose the previous doctor who was seeing him had not advised and you discovered this thing which could change his life, do you think reaching out to that previous doctor and talking to him could have actually helped? Because then there wouldn't have been this dichotomy in his mind of contradiction of one doctor with whom he had been on follow-up versus the new person. And the third is that most people never advise something expensive. There is always that little feeling that, look, what is the collusion between the industry and the doctors? Because,
Yes,
with
exactly.
product manufacturers and with doctors,
Yeah.
there is always that feeling. So, how do you address these three? And I'm again telling you with all humility, I'm playing the devil's advocate. I want it to be a provocative discussion.
So, I'm very happy that you raised these points, because actually this was not my intention at all to convey, because I always make it a point to make sure that I never criticize any previous doctor from whom the patient is coming to me. I've never done that. Not only this patient, any other patient also. And in this patient also, I told him that this was only a subtle finding. Although it was glaring finding, I told him it is a very subtle finding. It may not get fixed sometimes.
Manish, let's not go into the details of the case. I'm only trying to talk about
so
human
now I'm coming to that.
Difficult situation.
Actually, what happened was that he had visited many senior cardiologists in past. Now he had come to, according to him, a relatively junior cardiologist, not that senior that he was visiting. Then this cardiologist made some discovery. Now he wanted this, which the discovery was proved on MRI, which was confirmed at 3 different centers. Still, he wanted to go back to another senior cardiologist. So that was the question.
So did it irritate you?
Huh?
Did it irritate you?
No, this did not irritate me. This made me feel very sad.
Can I add? Can I interrupt? So I have a completely opposite thing, that why can't we criticize someone who has actually done a wrong thing of missing a diagnosis? I mean, how do we not tell a person? That's the question, I think, what Dr. Manish is saying, because as far as I know, Dr. Manish, he will not tell, which is counterproductive. If we are on the patient side, then and there is if you have to choose between your colleague and a patient, who do you choose? Is that the thing? If you have to choose between that previous doctor and the patient, you'll choose the patient, because it's for his safety that you need to specifically tell that previous diagnosis was wrong. Is it wrong to say that?
Yeah, actually, a very valid question. I did not do that, and I was thinking the same thing, that I should have said that actually, that you were not told, it's not my fault. But I never said those things, and still I was on the wrong foot.
Receiving end. Tejal, you want to come in quickly, and then Dr. Manish.
Oh God, extremely difficult to answer that. And I think it's a problem we face every single day in the clinic. And but I do acknowledge that there may have been a mistake. I do say that the intention was not to harm or to hurt, but in their expertise or knowledge, this is what has happened. And I think that when we speak in a manner which doesn't blame or shame the previous person and is explained properly, I think most of the time patients also are quite open to understanding that. I don't know.
Yeah, that didn't happen in this case. So, Dr. Shyam, you want to put in a point? Because if someone has come with a wrong...
Listening to this interesting conversation and Dr. Chaudhary's point, so we all come across actually these types of things. Sometimes we are on this type of side of the table, and sometimes maybe some of our patient is going to some other doctor and he might be telling the same thing, that previous doctor did the wrong diagnosis or the wrong treatment. So I'm not very sure. So usually in my personal practice, I usually try not to. Actually, there are some people who would just like to highlight the wrongs which are done maybe by the some other doctor. That I think that is wrong. You should try to actually, because see, everybody can commit mistakes, and there are, you sometimes don't know. Nobody does it by knowingly that he's doing something wrong. And doctors, I feel, always try to do their best. So even I see sometime I my conversation with patient is not good, and the patient later on is not happy. He can put on some negative remark which I feel offended, that this is not the thing. I did my best and I did whatever I could, but and maybe he goes to somebody else and then he says something negative. So maybe if I got some new finding or something which was not previously known, or something discovered because of the in view of new investigation, or maybe new clinical evidence. One is the imaging and there is a clinical evidence. Then I would say maybe this was not there, or even actually sometimes patients want to hear that previous doctor did something wrong. They want to hear. They will tell that I went to these 2 3 doctors and this doctor and he did not do it well. And then he would increase your, he is this thing, that because then he started criticizing those previous doctors and started praising you. So you become one of the victim of that then you want to make
No,
that
I
person
think, I
happy.
think, I think if we move the discussion from the doctor to the problem there, suppose someone has missed a life-threatening diagnosis, Dr. Manish,
Yeah.
and the patient comes to you, and you can see this. And to counsel the patient properly, you need to tell this to the person that this was missed. How would that conversation go? I mean,
I
this
think
is
I
not
think
about how you feel.
Dr.
This is about
Dr. Shyam Bansal has nicely answered this question. Uh, uh, you might say that we are a bit diplomatic, but actually, ultimately, we respect our profession too much. It's not about blaming somebody else, but it is about the profession. It's a professional ethics which we follow. That's why we don't blame anyone. We suppress our own feelings. And the question is whether your telling is going to alter the course of the illness and treatment. Is it going to alter the course of the treatment very much or to a significant extent? Then you must tell. Otherwise, the fact that the patient has already left that doctor and came to you, so you are controlling the situation. So why should you go back to that part if it is not going to alter your decision making and the situation and the patient's treatment? The patient is going to follow your advice, and by telling that, are you going to actually change or are you going to actually benefit? Is the disease going to get cured by just telling the fact that somebody had made the mistake? I usually do not use the word wrong. I use the word inappropriate. Or sometimes I even document this medication was prescribed for reason, for ill understood reason or something. I document it in my prescription also sometimes. Sometimes suppose something should not have been given, but once I stop it, I should move forward, look forward. Because if blaming the doctor helps me or helps the patient into a significant way, yes, maybe you can do that. But otherwise, in most of the situations, that's not going to happen. So I think we should leave it there and should look forward. Am I sounding too diplomatic here?
yes, you are.
You want?
We will come to
I appreciate Dr. Manish Barua's point. I'll tell you the issue. Wrong and right are very judgmental words. I'll tell you this, we have evolved over a period of time. And the question comes is that, are you really in a position to judge and pass a judgment? Because if you do that, then you are also vulnerable to other people judging you. So the question is, no, in one case it's okay, but there is a diplomatic way of getting past it. If there has been call it an oversight, or call it that, there have been differences in approach and your approach is entirely different. But as they very rightly say, amongst doctors, you don't need enemies here. You have your own colleagues as your biggest enemies.
No, sir, there is hope. There is hope. I refuse to believe
so
that
I think
it is
that
as
how
bad
to
as
negotiate that is a very important issue.
Can I come
Doctor,
in for just
so
one second?
please, Chitra. Then I'll just read Dr. Bhanu's comment after this. Yeah.
I think when you praise, you should praise specifically, and when you criticize, you should criticize generally. I think Warren Buffett said that. So if the practicing GP has done well, let the person know that your GP is doing a great job taking care of you, right? And if you think that something is missed, maybe recommend that maybe once in a year or so, come in to meet a specialist in a city, because for all that we know, the GP might be the only healthcare provider that the patient has access to through the year, right? And we sit in our cities comfortably thinking that everybody should seek a specialist care for all individual cases, as much as we might have specialized and add value and make difficult diagnosis. I think that is something that we should be aware of. I think we should not criticize as much.
I would quickly read Dr. Bhanu. He is a pediatric endocrinologist, my colleague. He is in the attendees here. I wish he was also a panelist. So he's written, there is always a possibility that decision made by previous doctor might be appropriate based on the situation and presentation at that time. We all have noticed changing history, vanishing and freshly appearing signs, which might change the entire scenario. So that was his. So Venkata Vemuri also has written that there is a point what Dr. Barua has said. So Dr. Barua, you have a lot of hands in your favor. We'll move to the next discussion now. Thank you very much, Dr. Manish. I completely think that because we were discussing similar situation with another endocrinologist who told me that I had a case where an acromegaly was missed for years, and how do I tell that patient something like that? The tumor had gone very large. There was a case in recently in transplant where there was some error and you didn't know how to who to blame, how to put that case in front of the patient. That is always an ethical challenge. There is no single one right answer, because if you say that you are always with the patient, there may be sometimes some displeased friends. That is what I feel.